Thank you very much for inviting me to speak here. Now I will move a little bit from neurodegeneration to acute conditions and focus on mild traumatic brain injury and show you some biomarker work we have done on this. This is a field in medicine which has very low level of standardization, and Sanne Lindström will talk about his experiences of being in a profession where you can expect to get concussed regularly and how concussion is dealt with in practical medicine. And it's actually a bit frightening, and it makes studies a little bit hard also because a concussion or a mild traumatic brain injury could mean almost anything. But you will hear much more about that from Sanne, and I will also address it from a biomarker perspective in this presentation. We have used acute brain conditions also to learn more about the dynamics of the biomarkers to inform clinical trials in neurodegeneration. How dynamic are biomarkers? How rapidly do they change in response to an acute trauma? What could we expect from biomarkers in terms of detecting treatment effects in clinical trials in neurodegeneration? So that's another aspect of the work we have done. Why would one like to have molecular biomarkers for acute brain injuries? One obvious reason is, of course, to detect injury to the brain after a head impact. Because if you get a hit to the head, it doesn't mean that the brain has been affected. You can feel quite bad after having had a hit to the head, especially if you break your nose or if teeth fall out, but the brain might have been completely unaffected by that hit. So we need something that can tell us if the brain was really affected by the hit. For example, if you look into combat sports, people get often very angry when they see mixed martial arts, when people beat up face, the blood is going everywhere, someone is lying down and someone is punching on the top. The person lying down is trying to fix his or her head to the carpet so that the brain will not rotate. As long as that fixation is successful with the neck musculature, with the protection, and of course the floor, then the brain is not injured, you're not knocked out, but you bleed and it looks terrible, but the brain is not impaired. So that's one reason why we need molecular biomarkers. Predict recovery time. If you have had a concussion, if you've been knocked out, when can you return to playing where you might risk new concussions? Most data indicate that one concussion is not that dangerous. Most often you recover well. But if you get new concussions before your brain has recovered properly, that has been linked to this disease entity called chronic traumatic encephalopathy, the prevalence of which is completely unknown at the moment. It's most often case series. But there one could potentially use the biomarkers to tell when could it be safe to return to a sort of a risk situation. So a return to play test also, that's another potential use. And finally, if you have had a number of concussions, the molecular biomarkers could potentially be used to tell if there is ongoing neuronal injury, or if there are no such signs. Perhaps one can actually look at if there are psychological side effects of the situation you're living in, and if there are other reasons not related to the brain injury. So the hope with this research is that one could get objective biomarkers to make the field more standardized and objective, so you could more objectively verify if the brain has been injured or not. So we have, many of you, and our lab has also done that. We have developed a lot of biomarkers for different parts of the brain, different subcellular components also. We now have synaptic markers, we have axonal markers, we have markers that are related more to the neural soma, the dendritic tree, the blood-brain barrier, and of course the astrocytes and the microglial cells. We are currently, as I alluded to when we sat in the panel here, we are missing good biomarkers for TDP43, which I think is an important field of research. We have tried, you have tried, Charlotte, there are other groups who have tried. We can measure TDP-43 in CSF and in plasma, but it doesn't reflect the pathology. It's simply, we just get the signal, but it doesn't relate to the pathology. Alpha-synuclein is a little bit like that too, although there are some promising assays detecting alpha-synuclein seeds in CSF. In this talk now I will focus on neurofilament light, which is a structural protein highly expressed in axons. The expression is the highest in large caliber axons. And then I will also show some tau data. And if you look in immunohistochemical slides of the brain, tau is more highly expressed in the cortex, in thin, unmyelinated axons, in potentially interneurons, while neurofilament light is more abundantly expressed in large caliber axons. So it's not black and white by no means, but it's at least one can look at it a little bit like that. And just by looking at the biophysics of a head impact, then the long axons are more likely to disrupt when the brain rotates in the skull than the shorter ones, and that's what our data indicate too. So we started with this many years ago when we started with cerebrospinal fluid, because we are based in Sweden then, and you have all learned now that here we do this all the time. So what we did was that we thought like this: where should we start if we are interested in concussion and we would like to detect biomarkers for concussion? Of course we should ask people who voluntarily expose themselves to a lot of concussions, and these are the boxers. Boxing is the sport that really stands out in terms of hits to the head and also head impacts, and the knockout of course that's a super concussion of course, and that's what it's all about. So we asked the Swedish Boxing Association if they were willing to collaborate in the study where we could learn about biomarkers for CNS injury. They said no. Then I asked a local boxing club in Gothenburg, where a guy called Olof Johansson, he was the chair of that boxing club, and he writes about boxing in the Encyclopedia Britannica, scientific perspective. And he said, I'm interested in any aspect of boxing, so of course we will take part in this study. And I asked him, do you really think we can do CSF sampling? And then he told me, if I tell my guys to do it, they do it. And that I didn't tell the ethics committee, because that could have been a problem. At least we had the signatures from all players. So what we did was that we included 14 amateur boxers. They were competing for the Olympics. They are high-level boxers, amateur boxers, but with helmet. Now in Sweden the helmet is gone, but the helmet didn't protect the brain. It just protected against cuts. Anyhow, 14 amateur boxers, 10 friends of those boxers. They used a little bit more marijuana. The amateur boxers were really straight-edge people. Then looking at the dynamics of neurofilament light in stroke, we knew that from before. The peak level is 7 to 10 days after a stroke. So we did the same with the boxers. And here are the results. Here you have controls, and here you see boxers after having taken part in an amateur boxing bout with levels that are very high. And then we resampled the boxers after the summer rest, where they could exercise but they didn't compete. And then the levels are down here. So neurofilament light, a large amplitude of the change. These boxers won, these lost. So the high levels, it could potentially be used as a surrogate for the boxing referee, I think. GFAP, which is a glial filament, also increased after the bout and reduced after the summer rest, but the magnitude of change was not that large. So, and tau looks like this. So you see an increase after a boxing bout, but it goes down. But the magnitude of the change is less than for neurofilament light. So that's why neurofilament light has become our favorite concussion biomarker. And I think that then again has to do with where neurofilament light is expressed and where the disease process in concussion is the most important. The long axons that tear apart when the brain rotates in the skull when you have a hit to the head. We are also asked for, we also looked for Alzheimer pathology, because we were thinking if these are high-level boxers and there are hypotheses that one could get plaque and tangle pathology from repetitive concussions, we measured those proteins as well, but we didn't see any such changes. So these boxers did not have early Alzheimer's pathology. They had axonal injury, but no sign of Alzheimer's pathology. Then we had to do it again because the Boxing Association was so angry with us. So they actually said that we will see if we can replicate this study together, but we could do it in collaboration. So we have some more boxers and some more controls, and essentially it looks the same. So after about, some boxers are up at levels that are really pathological. And if you look at these levels, when I work in the clinical neurochemistry laboratory, these levels are significant. So levels like this you see in minor strokes, you see it in multiple sclerosis, and you see it in, so you don't, these are not levels that are sort of, well, that you can see these levels sometimes. These are levels of brain injury in the boxers. Again, no signs of Alzheimer's pathology. So it is actually, concussion is really a pure, from a biomarker perspective, a quite pure axonal injury. Here's a knocked out boxer. So this boxer competed up in northern Sweden and had a knockout punch. Then he came to us because he had read about these studies, and he wanted to have his CSF neurofilament light levels checked. And then he said that he wouldn't box again until the levels were normal. So he came here 10 days after the knockout punch with very abnormal CSF neurofilament light levels. Then he came back 2 months after, and you see the levels have gone down, but they are still quite abnormal. Then he came back here 4 months, still a bit abnormal. Then actually he got tired of this biomarker work. So he took part in a boxing bout there, but he broke his thumb, so he didn't have that much. The game was interrupted in the first round. But you see here, it took 8 months for him to normalize in this injury marker. And of course, we do not know if this was ongoing injury or if this was just Wallerian degeneration after the knockout punch that he received. So perhaps this is just, perhaps it's fine to expose yourself here to new. No, if he hadn't done like this, he would have boxed here after 2 months, and then he might have. I mean, it would be very interesting to follow boxers more closely and see what levels they end up with. And I think this could be one reason for why, if you look in professional, if you look at good professional, the lists of good professional boxers, it's very hard to find people who are older than 60 and not, who do not have neurological problems. So it really, I think boxing really stands out as the concussion sport. The levels are dynamic. You saw how they went down. This is something that Jens will talk more about later also, but when you look at neurofilament light levels in relation to successful treatment, for example in multiple sclerosis, you see that the levels really normalize. And this is a type of slide that we would love to see in the field of neurodegeneration, of course. And we haven't seen it yet. So I'm less interested in the amyloid markers. There was a question on that before, in the amyloid targeting therapies. Of course, it should be used for inclusion. But as a follow-up of a downstream treatment effect, I think we should look for neurofilament light. A drug that detoxifies or removes amyloid from the brain should lower neurofilament light in Alzheimer's disease if it is effective, if it does something to the neurodegenerative process. And that's why I think we now also should look into all the samples that have been collected in the interrupted trials, because there we could do neurofilament light also on blood, as Charlotte pointed out, to see if the amyloid engagement really did something to the neurodegenerative process, which I think would be a very important result to our field, to know that. I think, I would expect that they didn't do anything to neurofilament light, but I do not know. But I think we should bravely analyze neurofilament light in all Alzheimer trials that have been stopped or closed negatively. This is, again, addressing neurofilament light dynamics. So here you see neurofilament light levels in children with spinal muscular atrophy, where we have an effective treatment now. So the treatment is quite clever. You inject in the lumbar sac an antisense oligonucleotide that modifies the expression of a protein that is lacking in spinal muscular atrophy and restores it, not completely, but to a large extent. The time points here are sampling time points. So they coincide then when you inject the treatment, the drug, the oligonucleotide. So here you have at 1 month, 2 months, 3 months, and then it's a little bit longer. So here is approximately 6 months actually this time point. And you see here that when you give the drug, you stabilize the protein, the spinal neurons will survive, the biomarker goes down. So it really works from that point of view. I'm curious about this one, what happens here, because it's not a trivial treatment and that doesn't work for everyone. But again, the biomarker moves in acute conditions and in response to successful therapy. Here we have another way of looking at the dynamics of neurofilament light. So if you have an HIV infection, the virus will rapidly move into the brain and it will injure myelinated axons. So here it's a little bit of a busy slide, but I will try to explain it to you. Now there are 2 screens here. Here you have a primary HIV infection. The patient comes in with fever and flu-like symptoms, and then the infectious department in Gothenburg took samples and performed spinal taps. So here you see up here the CD4 cell count, normal. You see high levels of viral RNA. You do nothing with this when you have this until the CD4 cell counts drop. Then you initiate antiretroviral therapy. And here you see neurofilament light levels in the lower part of the graph here. You see neurofilament light levels. They are pretty normal, but they go up as the CD4 cell counts drop. When you initiate treatment, the CD4 cell counts recover, so the treatment does what it should, and neurofilament light moves down like this. These are repeated CSF samplings. You asked about how many times you can do a new lumbar puncture, and on the x-axis you see the age of the person. So it is, I mean, if you do it carefully, with you give some coffee and a bun, and it should be a pleasurable situation, then it works. Here is this is a subject who came in with low CD4 cell counts with HIV. HIV positive with low CD4. And here you see very high viral RNA levels up in the upper part, and then you see low CD4 cell counts. The patient starts out with abnormal CSF neurofilament light. And then in response to antiretroviral treatment, you bring down the patient here, and everything normalizes. And this is a case with HIV-associated dementia. Everyone who has an untreated HIV, if you go into AIDS, then you get demented. And then you see here very abnormal cell counts here when the patient came in, high HIV RNA levels, very abnormal CSF neurofilament light. Treatment is initiated, neurofilament light goes down, cell counts recover, and the HIV goes down. Here, the patient stopped taking therapy. Immediately, HIV comes back and exerts its damaging effects on the brain, and neurofilament light responds quickly. So I really think that we should be able to use this marker to detect treatment effects. And now we have seen it in so many different conditions, so I think it's... Now we move into ice hockey, Sami. So this is a study we did together with the Swedish Ice Hockey League, the Swedish Hockey League. The elite, I mean, they are super good. They are, you know, the NHL scouts are really looking into the Swedish league. The Finns are pretty good too. What do you say, Sonny? Yeah, the Finns are also tough. Yeah, that's always the Swedish-Finnish competition. Perhaps it's like US, Canada or something. I don't know how what. It was much easier to work with the SH, the Swedish Hockey League, than the boxers, because there is an awareness in the ice hockey world now, I think, that concussions are a problem. There are prominent people like Sunny who has openly talked about what happened to him. And young people are a little bit worried. Some parents are worried about this too. So it's a threat, a potential threat to the game. I mean, in Sweden, playing ice hockey is common. But if you enroll your kids in a sport where you then can expect them to get brain injured, that could really, perhaps I would be a little bit hesitant to that. My kids are so thin, so they wouldn't play. I think so. Here we see what we did here was that we looked at players who had repetitive concussions and who had symptoms. And this is a busy slide, but look at this in the blue bars here. There you see neurofilament light levels. Those who have symptoms and who have had symptoms for longer than 1 year, they have increased levels of CSF neurofilament light, indicating that something is still going on in the brain. You see that it's not at all diagnostic. The levels, there is an overlap. It's not diagnostic, but I think it informs us a little bit in regards to what repetitive concussions could, in some cases, start in the brain. The other biomarkers are not normal. It looks pretty normal, but neurofilament light stands out again. There is something that is not good not in all, but in some of these players. And then can this be measured in blood? Charlotte has already shown that it can injure the brain accidentally. When you treat head and neck cancer by radiation, then you will always hit the brain accidentally a little bit. And the higher the dose, up in the upper part here, you see that these are low brain irradiation doses. But when you have higher doses, then you see that the level increases. And here we have serum neurofilament light levels in ice hockey players who have post-concussive syndrome, and you see that you also see this in blood. So one could use a much more simple than blood test to detect this. So in conclusion, neurofilament light seems to be actually the most promising biomarker to detect brain injury after acute traumatic brain injuries, also after concussion, but you will see that you will most likely detect a subgroup of concussed individuals who really have axonal injury. It's a dynamic marker. The timing of the sampling is important. One shouldn't take the samples too early for neurofilament light. GFAP and tau, I didn't show much data on that, but they are faster. That's another. So if you would combine tests, GFAP and tau could be early tests, and neurofilament light could be after a week or so, or 5-6 days. And for late symptoms, neurofilament light seems to be a really promising biomarker. Then there is a lot of additional research going on that I didn't cover at all that relates to microRNAs and exosomes and all those things, but that we have to, that's literature one can follow. And here's the team in London and Gothenburg. Thank you.